Welcome all. We have another talk on the diabetic ketoacidosis in pregnancy. So this talk article, we will discuss about the diabetic ketoacidosis. So what is the basically core concept here? This diabetic ketoacidosis, it is a medical as well as obstetric emergency. And this is mainly caused because of the insulin deficiency. And generally, there are increased counter regulatory hormones such as cortisol, glucagon, catecholamines. These hormone levels are increased and there is a simultaneously insulin deficiency. That is what is the scenario which you get. Okay, what it will lead to? It will lead to one, hyperglycemia. Second, it will lead to ketogenesis, and that will lead to the metabolic acidosis. Okay, so hyperglycemia is there, and there are ketone bodies which are produced, leading to the ketogenesis. Okay, and metabolic acidosis. Okay, why the pregnancy in pregnancy there is a increased DKA risk? Because pregnancy predisposes to diabetic ketoacidosis due to the reduced buffering capacity from the respiratory alkalosis and increased insulin resistance from the placental hormone, leading to accelerated ketogenesis. Okay, so what happens during pregnancy? Pregnancy is a there is a respiratory alkalosis during pregnancy. Okay, now because of the respiratory alkalosis, this buffering capacity is reduced of the blood, and there is a insulin resistance because as the pregnancy advances, these anti-insulin hormones such as placental hormones, they are increased, and that also leads to the increase or accelerated ketogenesis. So this respiratory alkalosis reduces the bicarbonate, that reduces the buffering capacity of the against the acidotic condition. Then placental hormones such as HPL, okay, then progesterone, cortisol, that is human placental lactogen, progesterone, cortisol, these hormones, because of which there is an increased insulin resistance, and they will also increase the lipolysis, leading to the ketone body production. So this is what is the pathophysiology during the pregnancy. So from examination point of view, remember diabetic ketoacidosis occurs at lower glucose levels than in the non-pregnant state. Okay, so which are the precipitating factors? Hyperemesis gravidarum, starvation, infection, insulin non-compliance. Then generally the patients are given the steroids for lung maturity, that can also precipitate diabetic ketoacidosis. Yeah, sometimes the patients are given beta agonists for tocolysis, and insulin pump failure is one of the important cause for diabetic ketoacidosis, and there may be gastroparesis also. So these are the causes, precipitating causes for the diabetic ketoacidosis. The clinically patient will present with nausea, vomiting, abdominal pain, polyuria, polydipsia, tachycardia will be there, and signs will be the small breathing, altered consciousness, shock, coma, hypotension. These will be the signs. Okay. On CTG, there will be abnormal CTG. This is mainly because of the maternal acidosis. Okay. So diagnosis will be on, you will find the ketone body level more than or equal to 3 millimoles per liter, or urine ketone more than 2 plus or equal to 2 plus. Glucose level will be more than or equal to 11 millimole per liter. It may be lower in pregnancy also. Okay. And pH less than 7.3 or bicarb less than 15 millimole per liter. Along with that, you will get the anion gap more than 12, and potassium often either normal or it may be high also. Potassium level is generally variable. Okay. But blood ketone level more than or equal to 3, urine ketone level more than or equal to 2 plus, glucose more than or 11 to more than or equal to 11 millimole, pH less than 7.3 or bicarb less than 15 millimoles. These figures you should remember, because generally they'll give you the long scenario, they'll give you the investigation, they'll ask you what this condition is. Okay, and then it will be metabolic acidosis secondary to diabetic ketoacidosis. Okay, so additionally, anion gap is more than 12. Sometimes there is a scenario which is related to the sepsis also. Generally, there is one question on this. So these values you should be knowing. Okay, so coming to the management. So management, it has got a 6 pillars. One is IV fluid, second IV insulin, third electrolyte correction, fourth bicarb is to be avoided, fifth is to treat the cause, and maternal plus fetal monitoring. So these are the 6 pillars in management of the diabetic ketoacidosis: IV fluid, IV insulin, electrolyte correction, avoid bicarb, treat the cause and go for maternal and fetal monitoring. Now, how much fluid is to be given? You need lots of fluids, and the fluid of choice is the normal saline. So 0.9% saline will be given 1 liter in 1 hour, 2 liters in 4 hours, and 2 liters in 8 hours. Okay. So 1 liter will be given in first 1 hour, followed by 500 ml per hour for 4 hours. That is 2 liter in 4 hours, then 250 ml per hour for 8 hours. That means 1 liter in 1 hour, 2 liters in 4 hours, followed by 2 liters in 8 hours. Okay. And after that, you put the patient on 150 ml per hour. Okay. If the shock is present on admission, if the blood pressure is less than 90, you give 500 ml bolus. Okay. So that will be additional. You may have to repeat this. Okay. Then we will add dextrose. If when the glucose is less than 14 millimole per liter, we will add the 10% of dextrose, and we'll start at 125 ml per hour. Okay. So we should target that the urine output is more than 0.5 ml per kg per hour. Next is the insulin therapy. But before starting the insulin, most important. So first is the IV fluid, but after that, because if the EMQ comes and they give you the scenario up to what level the treatment is given, that you should know, and then you should be able to predict the next step. Okay. So you will give the IV fluids first, but before giving the insulin, you should first see the potassium level. Never give the insulin without measuring the potassium level. If the potassium level is more than 3.3 or equal to 3.3, then only you will give the potassium. Okay. So IV infusion will be given. Insulin infusion will be started if the potassium is more than 3.3 millimoles per liter at a rate of 0.1 unit per kg per hour. Okay. No bolus is required. Okay. Then target response should be the ketone body should start reducing once you start with IV fluid and this insulin after the potassium level once you observe. It will reduce the ketone bodies by 0.5 ml per hour. Okay. And glucose will reduce by 3 millimoles per hour. And we will continue the basal insulin if already the patient is on. Okay. Now, when to stop this insulin? IV insulin will be stopped after once the decay is resolved completely, and after the subcutaneous insulin has been given with an overlap of 30 to 60 minutes. So once the diabetic ketoacidosis condition is there is a resolution, and you have given the subcutaneous insulin, then after 30 to 60 minutes, you stop this infusion. Okay. So stop IV infusion after decay resolution and 30 to 60 minutes after the subcutaneous insulin. Okay. You should also know the decay resolution criteria. What are the decay resolution criteria? What should be the ketone level after you start the treatment to say that there is a decay resolution? What should be the bicarb level? What should be the sugar level? That all is important. Okay. That also we'll see at the end. Okay. So potassium management. So as I mentioned, before giving the insulin, you will always check the potassium. If the potassium is less than 3.3, you will not give the, you will correct the potassium. You will not give the insulin. If it is between 3.5 to 5.5, you give potassium plus insulin. Now, generally what happens when the potassium level is normal, 3.3 to 5.5, it is a normal potassium level, but still you have to give the potassium along with insulin, because once you start the insulin, after that there will be hyperkalemia, because of the insulin, that will potassium will go intracellular. Okay. So you have to start this potassium plus insulin. If there is a potassium level more than 0.5, then we will not give the potassium. We'll give only insulin, because this insulin itself will correct the potassium level. Okay. So if the potassium level is normal, 3.5 to 5.5, what is to be done? You add KCl 40 millimoles per liter. Okay. The maximum infusion rate should be less than or equal to 20 millimoles per hour. Okay. So key concept is that total body potassium is depleted. So serum potassium may be normal or high initially. Okay. That is why if the potassium level is normal, then also you have to give the potassium along with insulin. Then another thing important you should know, bicarbonate. Bicarbonates are not recommended in diabetic ketoacidosis management, because this bicarbonate will shift the oxygen hemoglobin dissociation curve to the left, and hemoglobin will hold to the oxygen more tightly. Okay, so because there is a oxygen dissociation curve will get shifted to the left. Okay, and that will lead to the decreased fetal oxygen delivery, paradoxical CNS acidosis. It will worsen hypokalemia, delay in the ketone clearance. Okay, phosphate are not used routinely. Okay, it is indicated if only less than 0.32 level or cardiac or respiratory compromise. Then next step is you have to identify the cause and treat the cause. So history and examination is important. Infection screening, pump you will check, drug history you will take, and if there is an increased leukocyte count, that is always suggestive of infection. Okay. Then maternal fetal monitoring is required. What you will monitor? Hourly glucose, ketone levels, electrolytes, urine output, and continuous cardiac monitoring will be done. For fetus, you will do the CTG. But remember, fetal distress, if it is there, it will improve with the maternal correction. So don't rush for the delivery. You correct this maternal acidosis, most of the time this fetal distress will improve. Okay, so this patient should be in the HDU or ICU, that is level 2 or ICU care is required for these patients. And what is the treatment target? The ketone level should be reducing by 0.5 millimoles per liter per hour. There should be increase in the bicarb, which is noted by 3 millimole per liter per hour, and glucose should reduce by 3 millimole per liter per hour. So bicarb should increase by the same 3 millimoles per liter, and glucose should reduce by 3 millimoles per liter, and the ketone body should reduce by 0.5 millimoles per liter per hour. Okay, so from examination point of view, remember diabetic ketoacidosis can occur with normal glucose level also. Pump failure, there is a rapid chance of decay. Steroids can precipitate decay. Do not give bicarb. Do not start insulin if potassium level is less than 3.3. Delivery is not the first step. Okay. And certain things which you should not get confused. High glucose is required for decay. No, in pregnancy, even euglycemic patient can have the decay. Okay. Give insulin immediately in all cases. No, before giving the insulin, what you will do? Check the potassium first. If potassium level is less than 3.3, then you will correct the potassium and delay the insulin. Okay. Then give bicarbonate to correct the acidosis. Even if there is a acidosis, you don't give bicarb because it is to be avoided. It is harmful and does not have benefit. Do we have to deliver the fetus urgently? First, maternal stabilization. Fetal distress is often reversible in these patients. Then potassium, if it is normal, does it mean that there is no need for replacement? Even the potassium is normal, 3.5 to 5.5, you will give insulin plus glucose because there is a total body potassium deficit is always there. So replace if the potassium is less than 0.5, 5.5. Okay, so if you in one line you remember it is a fluid first, insulin if potassium safety is ensured, then replace the potassium. No bicarb is to be given. You will treat the cause and monitor the mother. So these are the steps in management of the DKA. Okay. So same thing what we have discussed, 6 steps. One is IV fluid. The rate of IV fluid will be, how much is the rate? 0.9% normal saline, 10 to 15 ml per kg per hour. Yeah, 10 to 15 ml per kg per hour. 1 liter in 1 hour. 2 liters in 4 hours and 2 liter in 8 hours, followed by 150 ml per hour. Okay. Okay. So when the blood glucose falls below 14 millimoles per liter, then you will add 10% glucose. You will start it at 125 ml per hour to the ongoing saline therapy. Okay. So this is what is the IV fluid. Okay. IV fluid management. So after IV fluid, before giving insulin, you will check the potassium level. If the potassium level is less than 3.3, then you will not give the insulin, but you will give the potassium. Okay. And you will do the potassium replacement. You will monitor the urine output. Okay. And once the potassium level is normal, that is 3.5 to 5.5, you will give both insulin plus potassium. You will monitor the urine output and you will go ahead with the potassium replacement along with the insulin. Okay. How much potassium you will add? 40 millimole per liter of the you will add. Okay. So that you need to continue. If and along with that, you will continue with the insulin. So rate of the insulin will be 0.5 unit per kg per hour. Okay. And it will be increased by 1 unit per hour if there is metabolic targets are not achieved. Okay. So the rate you will give 0.1 unit per kg per hour. Okay. and you will stop once there are resolution criteria, and once you have given the subcutaneous dose of insulin, and after 30 to 60 minutes of that you will stop it. And if the potassium is more than 5.5, you will not give potassium, but you will give only insulin. Along with that, you will find out the cause for the DKA, you will treat the cause, you will do the maternal monitoring, you will do the fetal monitoring. Okay, so these are the important steps. And what are the DKA resolution criteria? The DKA resolution criteria, the blood ketone level should be less than 0.6. Okay, that means less than 0.6. Normal itself is 0.5 or less. Okay, so blood ketone should come down to less than 0.6 millimeter per liter. Then pH should be more than 7.3. Bicarb should be more than 15 millimole per liter, and anion gap should be plus or minus. How much should be the anion gap? 12. Okay, should be less than 12. Okay, so that is what is the resolution criteria for the diabetic ketoacidosis. So we have few questions. Doctor, can you please answer these questions? Just a moment.
Yes, sir.
Yeah.
A 26-year-old at 30 weeks with type 1 diabetes present with DKA. Investigation shows glucose 18 millimole per liter, ketones 4.5 millimoles per liter, and K plus is 3 millimole per liter. What is the most appropriate next step? A. Start IV insulin immediately. B. Give IV bicarbonate. Start IV potassium replacement before insulin. D. Start insulin with potassium simultaneously. Or E. Give dextrose infusion. It is C. To start IV potassium replacement before insulin.
Yes. So first is a fluid correction. You
Fluid
look for before insulin, check the potassium. Okay, potassium is low, correct for the potassium. So start IV potassium replacement before insulin. Less than 3.3, insulin is contraindicated initially. Okay, insulin will worsen hypokalemia. There will be risk of arrhythmia. Next.
A 32-year-old at 28 weeks presents with vomiting and lethargy. Her glucose is 9 millimoles per liter. Ketone is 4 millimole per liter, and pH is 7.25. What is the most likely diagnosis? A. Starvation ketoacidosis. B. DK ruled out due to normal glucose. E. Euglycemic DKA. D. Lactic acidosis. E. Hyperosmolar state. It is C. Euglycemic DKA.
Still, it is
Ketones
on
are
higher
raised.
side actually, but euglycemic decay. So pregnancy decay can occur at lower glucose levels. Okay.
A
Next.
pregnant woman presents with DK and hypotension. What is the first step in management? A. Insulin infusion. B. IV potassium. C. IV zero point 0.9 saline bolus. D. IV bicarbonate. E. Immediate delivery. It's C. IV 0.9% saline bolus.
So it's correct. Okay. 0.9% saline fluid therapy in all decay, restore perfusion, and improve insulin sensitivity. Next.
A woman with DK has K plus 4.5 millimoles per liter. What is the most appropriate management? A. No potassium, start insulin. B. Start potassium and insulin together. C. Delay insulin. D. Give bicarbonate. E. Give potassium only. It is B. Start potassium and insulin together.
Because the potassium is normal, 4.5, 3.5 to 4.5. So give potassium. Next.
Pregnant woman with DK has K plus 6 millimole per liter. What is the most appropriate management? Give potassium immediately, withhold insulin, start insulin, no potassium, give bicarbonate, delay all treatment. It is C. To start insulin without potassium.
Yes, start insulin without potassium. Potassium more than 5.5. Insulin will reduce this potassium. Next.
Women with TK started on IV insulin. What is the correct starting regimen? A. Bolus insulin followed by sliding scale. B. Fixed rate of zero point 0.1 unit per kg per hour. High dose insulin of 1 unit per kg per hour. D. Subcutaneous insulin only. E. No insulin if the glucose is less than 14 millimoles per liter. It is B. Fixed rate of 0.1 unit per
Yeah,
kg.
you'll start at 0.1 unit per kg per hour. If there is no response, then you will increase 1 unit
1
per
unit per kg per hour.
no, not per kg. I think it is per hour.
Per hour. 1 unit per hour.
Standard is a 0.1 unit per kg per hour IV infusion. No routine bolus dose is required. Okay. Next.
During treatment of DKA, glucose falls to 12 millimole per liter. What is the most appropriate next step? A. Stop insulin. B. Add 10% dextrose infusion. C. Increase the insulin rate. D. Give bicarbonate. E. Stop fluids. That is B. Add 10% dextrose infusion.
Yeah. So once the glucose falls down, then you will add
Below 14.
10% of glucose, because when glucose is less than 14, we are continuing the insulin to clear the ketones. Next.
A clinician considers bicarbonate therapy in DKA in pregnancy. What is the most appropriate statement? A. Routinely recommended. B. Improves fetal oxygenation. C. Delays ketone clearance and may harm the fetus. D. First line in severe acidosis. E. Required if pH is less than 7.3. The C. Delays the ketone clearance and may harm the fetus.
Yes, it is. It will delay the ketone clearance, so it is not recommended. So it reduces the fetal oxygen delivery, causes paradoxical CNS acidosis, and not recommended. Next.
A pregnant woman on insulin pump presents with DKA after pump disconnection for 4 hours. What is the most likely explanation? A. Increased insulin resistance, absence of long-acting insulin. C. Infection. D. Excess insulin. E. Presental hormones. It is B. Absence of long-acting insulin.
Yes, because only rapid acting insulin can be given. Insulin pump failure, pump will give only rapid acting insulin. So interruption will lead to the decay. Okay, next.
A 29-year-old at 32 weeks present with DKA and abnormal CTG. What is the most appropriate management? A. Immediate cesarean section. B. Induction of labor. C. Stabilize mother first. D. Give tocolysis. E. Deliver if CTG abnormal. It is C. Stabilize the mother first.
Yes. So she is 32 weeks. There is decay. CTG is abnormal. You stabilize the mother first. Most of the time, it is because of this metabolic acidosis. The CTG is abnormal. There is a fetal acidosis secondary to the maternal acidosis.
Maternal
So if
acidosis.
you correct the decay, most of the time the CTG will improve. Okay, do not rush for the delivery. Fetal distress is secondary to maternal acidosis. So correct the maternal condition first. Okay, so final take home message is that less than 3.3 potassium, no insulin is required. Give potassium. 3.3 to 5.5 insulin along with potassium. More than 5.5 insulin only. Okay, fluids before insulin. Insulin only if potassium more than 3.3 or equal to 3.3. Add dextrose when glucose is more than 14, less than 14. Okay, no bicarb. DKA can be euglycemic also. Delivery is not the first step, and pump failure, there is rapid chance of decay. Okay, that finishes this talk article also. Thank you.